there are some areas that we compete, but, our goal together is to offer superior health care for Beckley, Raleigh County, and the surrounding region. So I think this area is very fortunate to have two great health systems in the area. When you look at health care in West Virginia, there's only 72 hospitals in the entire state, 31 of those being general acute care hospitals and 21 critical access hospitals. So when you think about 31 full-service hospitals in the state and having two of those right in Beckley, Raleigh County, very, very fortunate. We heard a lot earlier today, even our last speaker, the Secretary, talking about economic development and jobs. And the thing that we know is that economic development doesn't happen if you don't have good schools and you don't have good health care. And I think from that standpoint, we are well positioned in Raleigh County to do great things, and I know both of our organizations are very happy to be part of that. West Virginia hospitals directly employ about 54,000 people across the state. We treat and release 880,000 patients from our emergency departments across the state, and we welcome more than 16,000 newborns into the world. So I think our healthcare system in West Virginia plays a huge role in the economy and taking care of our community. So we're going to introduce each of our individual hospitals. Todd?
Again, good afternoon. I'm Todd Howell, and I'll share a little bit about Beckley ARH. Beckley ARH, also known affectionately in the community as BARH, opened in January 4th, 1956. We just celebrated our 70th anniversary, so really proud of that. But we were one of the original 9 Miners Memorial Hospital Association facilities, and like I said, we just celebrated 70 years of providing care in the region. We're an acute care hospital. We're a nonprofit. We're 173 beds, 113 beds, and 60 psychiatric beds, and again, located in Beckley. We also operate the Southern West Virginia Clinic, which has primary care and some specialties, Beaver Family Clinic, the ARH Medical Mall, and the Rejuvenation Center, along with retail and specialty pharmacy. We're designated a Level 4 trauma center, and in 2025 received accreditation as a DNV primary stroke center. And I can't put this in here yet because it's just preliminary, but we were accredited Monday as a American College of Cardiology chest pain center. And I'll tell you just one thing, David was talking about, there's only 6 facilities in the state that have that. Raleigh General is one of those also, but really proud to get that recognition. So just talk a little bit about the scope of services. Again, we have a lot of similar services. I'm going to kind of focus on some of the things that maybe we do a little different. We have home care and we have home health as part of our portfolio of services. Our behavioral science is, we're probably the largest provider in Southern West Virginia. We're the only adolescent psychiatry provider in Southern West Virginia, so we get children from all over Southern West Virginia in our center. Our rehabilitation, we're really proud of a lot of that too. Physical, occupational, speech, cardiac and pulmonary rehab that we do for patients who are recovering from myocardial infarctions. And again, we talked about the level 4 trauma. I'll just show a few things that we have been doing recently. One of the things we participated in, you may have seen this, working with the President of the United States on food as medicine. So we just recently were teaching people in the community how to do healthy charcuterie boards as a way to eat healthy. We have a mobile clinic. We're always trying to educate the community. This is one of our oncologists who's educating about HPV prevention and protection. And we were recognized this past year as a Silvers Hospital with the WVHA Honors Program. So that's just some things about Beckley ARH.
So introducing Raleigh General, of course we have served Southern West Virginia for more than 100 years. We Obviously, our 300-bed hospital, but we average daily census of about 134. We have outpatient locations, also including the Raleigh Medical Complex, which is across the street from the hospital. Also like to mention some of the key accreditations and quality distinctions that we have at Raleigh General. Of course, the Chest Pain Center with PCI, Cardiac Cath Lab with PCI, our Primary Stroke Center designation. We are a verified Level 3 Trauma Center by the American College of Surgeons. That is the highest level trauma center south of Charleston. So very proud of that designation. We have a wound care center of distinction, operated by a company called Hologics for Raleigh General. And we're just very proud to let you know that we have received kind of the trifecta of awards for wound care this year. The President's Award, the Clinical Excellence Award, and I'm not recalling the third one, but we've won all 3 awards that Hologics offers this year, so very proud of that. And are also a Joint Commission Spine Center of Excellence with our orthopedic spine program. So very happy with, to have that. Again, our roots are deep in this area. Again, over a century that we've been providing care since 1922. When the King's Daughters Hospital was opened, and then in 1928 it was renamed as Raleigh General. We currently are owned by LifePoint Health and have been since 2006. That's a great thing for us because being part of a national organization that operates in over 30 states, you have the ability to withstand some of the challenges that were thrown in healthcare. And also the ability to learn from our colleagues across the country about new and emerging trends and staying at the forefront of what's going on in medicine. Some of the services that we offer, again, I pointed out the Level 3 trauma designation. We also do robotic surgery. We have a great urology program, orthopedics, including orthopedic trauma and the spine program. And so a full level of services, and as Todd mentioned, there's a lot of things that are common to both hospitals, but you know, we each have kind of our niche services that really gives the community a wide range of services to choose from.
All right, I'm going to ask a question now. I would just want to get some audience participation in this. So how many regulatory agencies do you think we're involved with or on a day-to-day? Just anybody would toss that? How many? 50, that's close. Anybody else? It's 34, about 34. 34 is a good guess. And so this slide shows that where we're at. We have a lot that is involved in what we do and the care that we deliver every day. You know, of course, some of the ones are very clear, like the Center of Medicare and Medicaid Services, but some of the ones are less clear. Like one of the ones that's involved with us, the FAA. We both have helipads that operate, and from those we have to have FAA clearance on, continue to meet criteria for the compliance on an FAA. So that is one of the areas that is involved with us. Another one is the Environmental Protection Agency. And you think, what in the world are you doing with the Environmental Protection Agency? Well, we deal with a lot of toxic drugs. We deal with a lot of toxic reagents that we use in labs, and how we process that. We don't want to be putting that into the disposal system, so we have a process that we have to make sure that we don't contaminate the environment with that. So those are just two of the things that you may not even think about that we have to deal with, along with 30 other ones that we have day to day. The Nuclear Regulatory Commission, the FDA, I mean, you could keep naming them, and they're involved with what we do. So what we do is very complex, and so that places a lot of requirements on us and a lot of challenges on us as we're trying to comply with all these laws and regulations to ensure that we provide great patient care in our community.
Yep. Yeah, Todd's right. I mean, we often think of a hospital as kind of a little city under one roof. I mean, you have your own engineering department, you have your own food service department, you have your own materials management, and you really have to be somewhat self-sufficient. So very complex organizations, and as we start talking about some of the things that keep us up at night and some of the challenges that we have in healthcare, that regulatory environment is one of those things. And when I first started in healthcare in 1988, the CEO I was working with at the time was called to testify before what was called then HCRA, the West Virginia Healthcare Cost Review Authority, and it's since been renamed, and the scope of what they regulate's a little bit different. But one of the things he was testifying about is just the complexity of healthcare and that regulatory environment. And there was a document that he used at that time in 1988 that was called, "What Does It Take to Run a Hospital?" And it just put into layman's terms just why the cost of healthcare is what it is and how difficult it is to function. And so I'm going to take just a second and read that. It said, "There's a way to make grocery store prices much higher than they are. As is, food is one of the consumer's best bargains. The cost of living would be much higher than it is, except for comparatively reasonable food prices." That part is probably not still true, right? Food costs have gone up. But there is a way to skyrocket those grocery store prices if you want to. If you want to multiply the prices of everything you buy at the grocery store, here's how. Subject your grocer to the same regulations under which hospitals are required to operate. That means the grocer would have to keep a record of the total number of customers served, broken down by employer. He would have to record the precise number of minutes each customer was in the store. The record must show which customers purchased only meat and nothing else, which customers purchased only bread and nothing else, which customers bought both bread and meat. Separately, the grocer's report must state which customers bought meat and milk. Also, the number of customers who came in for one item and purchased more than one. Further, the grocery store is required to give away $50,000 worth of groceries each year, and signs must be posted in the store in 3 languages telling customers that the store is required to do this. Records must be maintained on all customers and all groceries given away under this plan. Further, for one half of the customers, the store is not allowed to set prices. Government will determine those prices. And if those prices are arbitrarily held down to no more than last year's prices, then the store owner must pay his higher expenses by charging higher prices to the other half of his customers. But for that half, the store cannot collect cash from the customer. It must send a bill to the customer's employer. Further, the store manager is responsible for planning each customer's meals. If he errs in judging what's best, the customer may sue him. Also, the store must keep careful records of each can of peas sold by brand name, size, customer age, employer of the customer. Similar reports are required on each product sold. The store must certify in writing that each customer needs groceries before permitting him to enter the store. So pre-certification, pre-authorization, right? The store must have a committee to establish a shopping time limit for each customer. Any customer permitted to shop longer than the pre-established time may not be required to pay for his or her groceries. The store must have a written approval of the government authorities before adding or deleting products or brands. The store manager must have a master's degree in marketing. There are many more regulations to which hospitals are subject, but this is enough for you to understand why the cost of medical care have gone up faster and higher than the price of groceries. So that was a Paul Harvey commentary. So that was the rest of the story sometime around 1988. And while a lot of things have changed, there's a lot of truth still in those words from 1988 about how we function and the complexity of the healthcare environment. And I might have to remind who Paul Harvey is, right? That's kind of giving away my age a little bit, but so the next slide is, speaking to the government setting the prices. What you see in the media sometimes, you see, or on social media, you see somebody gets a hospital bill and they're wondering about that $5 aspirin and everything. But the reality is that most of our revenues are controlled by a government program. And what this slide depicts on the left-hand side is where West Virginia hospitals get their revenue, and you can see the green, only a small portion actually comes from employer-funded health programs. The majority, and in the case of Raleigh General, and I think BARH's number is very similar, over 80% of our revenues come from either Medicare, Medicaid, managed Medicare, managed Medicaid, so those prices are predetermined. Our reimbursement is predetermined of what we're going to receive from those payers. And it's why what happens in Washington, what happens in Charleston, has such a bearing on what happens here in our local community. At the stroke of a pen, life can really change for us here in the local community. The slide that's up on the screen here about Medicare and Medicaid payment methodologies, not all hospitals, not all physicians are paid the same. In our case, both BARH and Raleigh General fall into the top category there of acute care hospitals. So we're paid on what's called a prospective payment system. You know, based on a patient's DRG or their diagnosis, the payer sets the reimbursement for what that is going to be paid, regardless of really what it costs hospitals to provide the care. Some of the other models here, critical access hospitals, I know in the news today, I think is one of our health systems in the state is looking for critical access status for one of their facilities, not too far from here. And that allows cost-based reimbursement. So basically, in a sense, up to some limits, the more you spend, the more you get. Todd and our hospitals are incentivized more on efficiency and how we're able to control the cost and efficiently move people through the delivery system and get them discharged home. So a little graphical representation of that. You want to walk through that?
Okay. Yeah, so I've used this, I've used something similar, and I usually will kind of equate it to like McDonald's, because McDonald's is probably a good way to say it's a good way to compare it. So if you go to McDonald's and it costs you like, let's say $100 to run the meal service for breakfast, we'll just say that. If you only got 70% of that, that would be $70, but it costs you $100 to run it. So we start off with government payers already at a deficit on most of the time. So the way that our reimbursement is, and actually Medicare tends to be a little bit better than Medicaid. So if you're looking at Medicaid, we'll say that 50% that it would take. So I would get $50, all it cost me $100 to make up the difference. And the PIA is another one that we'll throw into that you might see. But where we make up the difference usually is commercial payers. So for somebody that has High Point, we may get paid $160 from them, where it costs me $100, but I still got 80% of my payers that are in that. So it makes us really have to focus on efficiencies. We have to be what David was saying is 100% accurate. We have to focus on how to be efficient. So if we've got a patient coming in for a pneumonia diagnosis and they're only supposed to get 3 days in the hospital, that's what they will pay us, and that's what they say that the patient needs. We really do try to focus on getting the patient out before 3 days, because we start losing even more on the other side. So that's just an example of the way our system works in hospitals especially. So.
Yeah, just a little bit about the two different programs, again, that we see a lot of our patients from, Medicare, Medicaid. Everybody's probably pretty familiar with those. You know, Medicare, of course, is a federal insurance program paid for by the federal government, covers the elderly, disabled people who receive Social Security. No pediatric benefits under that. Medicaid is a joint federal and state program, so a lot of money that comes in. We actually have a provider tax program where hospitals pay taxes based on their net revenue. That money gets sent up to the federal government and matched and comes back and funds the state Medicaid program. But those costs are shared by federal and state governments. Basically covers low-income adults, low-income families and children, pregnant women, elderly, disabled adults, and some other categories that vary by state. What we want to talk about a little bit, you know, our presentation was really to talk about some of the challenges we face, and I think really the things that keep us up at night, and there are really two categories I think we want to focus on today. One is hospital financial pressures, and the other is workforce. And I think it's very appropriate that our session being sponsored by educational institutions because, I mean, the workforce challenges are significant, and we will talk a little bit about those as we walk through. But I think, you know, based on the American Hospital Association, some information they put together, is hospitals face a perfect storm of financial pressure, persistent cost growth, and inadequate payment. So labor costs dominate hospital expense. Again, for Raleigh General, that's in excess of 50% of our expenses are, you know, related to personnel cost. I'm sure Todd's is close to that as well. Hospital expenses are growing faster than inflation. Between 2022 2023, prices for 2,000 drugs increased by an average of 15.2%, and I can safely say that our revenue did not keep pace with that, so a big challenge for us. The Medicare Advantage plans, we've got a lot of people that are in Medicare Advantage plans that increase cost on hospitals. Increase observation stays, so we're paid differently for outpatients than we are inpatients. So if someone is in an observation status, we're paid as if they're an outpatient versus an inpatient stay. And then we delaying discharges sometimes to post-acute care. Because of the approval process, you know, if we have someone that's ready to go to a long-term acute care hospital or ready to go to an inpatient rehab facility, sometimes there's delays to that end up increasing cost for hospitals.
And can I piggyback on the drug costs just for a second? This may surprise you or it may not. On some of the drug costs, like if we have, on the inpatient side, we have drug costs, but on the outpatient side too. So if we have a patient that is getting some of the newer chemotherapy models, some of the drugs for one patient cost $30,000 for the month. So that's what it cost us. So, you know, those charges go out to the patients, and we have to have the markup for our expenses for labor, for our pharmacy cost, our administration cost. And so we're talking about that, you know, I would have put a number out there to let you know. I mean, we've had some patients that their therapies are hundreds of thousands of dollars a year for one patient. And so it's a big impact. Now, are they making a difference in people's lives? Yes, but it's very expensive. So that just to provide a little context around that, what that means for some of those drugs. I say this all the time. If a snake bite comes into the hospital, I hear this. If I hear one comes in, I know in my head it's $50,000 in drug cost to get that crofab that you're going to need to treat that patient with a snake bite. We've got to do it, but I'm saying that has a big impact on what we're trying to do to manage our expenses.
Yeah, what we're seeing in West Virginia is really no different than what hospitals are experiencing across the country. And you know, they're really struggling to maintain access to essential services. You know, we've heard in West Virginia, you know, 2 OB units closing in the last, 60 days or so, those announcements. It probably would surprise you. You know, you look at the geography of West Virginia and how hard it is to get from one locality to the other. Anybody have an idea how many OB units are currently functioning in West Virginia? How many hospitals can you actually go to deliver a baby? Any idea? Only 18. So, you know, back in 2022, I believe that number was somewhere near 29. So we've had a lot, well, actually 2002, rather, not 2022, 2002. There were 29 hospitals that were delivering babies. And so, you know, some services just become really unsustainable, either for, you know, staffing reasons, you know, the physician recruitment or cost, that you just can't offer them anymore. And I think one of the reassuring things for this community is that we've got 2 hospitals that are in very stable shape, right? And we're doing well, you know, well utilized by our community. And, you know, we're hoping that those trends don't come to Beckley and Raleigh County. But it's just kind of hard to believe that, in a state the size of West Virginia, that there's only 18 hospitals that currently deliver babies. And other services, to Todd's point, the cost of cancer care, the cost of some other services, it just becomes unsustainable at some point. The other thing, as we talk about how we're paid, we're not really whining about that. That's not the point. We can't control that. The regulators, the government agencies, they tell us what we're going to be paid for over 80% of our patients. What we can control is the expense side and, what it costs us. But even those are getting harder and harder to control. The cost of what it is to recruit a physician to the community. Salaries for nurses, for example, have grown 26.6% faster than inflation the last 4 years. Starting before COVID, there was already staffing shortages. We were already projecting shortages of physicians and nurses, and then COVID, it just got times worse with people leaving the workforce, deciding to retire early, pursuing, alternate careers. It really the employment environment has really changed. And to the point we covered earlier, Medicare payment right now only covers about 83% of hospital cost. And that's on the average. Some hospitals will do worse than that. Some might do a little bit better.
All right, we're going to talk about workforce. We shared a minute ago about the regulatory agencies that we have to work with. I will tell you, on the workforce side is not necessarily from a regulatory standpoint, but we have probably 40 to 50 different jobs that we have in an organization. Now, for a lot of you that run businesses, you may have a lot of employees, but the job classes of employees probably aren't that different. So for us, we have a rad tech that has to have a degree in radiologic technology. They have to be certified. And then you go into the specialties around that. So if you have a CT tech, they've got to be CT certified. They've got an MR tech's going to be MR certified. So we have all these jobs that require advanced training, require advanced skills on that, licensure and certification. So we start off just saying that to say that is a challenge already. It is difficult to get people. We're in a very competitive market, in the whole United States, not just here in West Virginia. Again, for these people, we've talked about physicians, but again, on the workforce side, for pharmacists, for other people like that, it's very competitive. So that is one of the things that is facing us, is how we deal with the workforce shortages. Again, we have shortages across all clinical and non-clinical positions, nursing, materials management, respiratory therapists, rad techs, pharmacy technicians, lab technicians. If we're talking about physicians, again, the American AAMC projects a shortage of 86,000 physicians by 2036. The U.S. Department of Health and Human Services expects deficits across behavioral health workforce by 2036. Rural hospitals are especially vulnerable. Without sufficient providers, many facilities will be forced to close or reduce services, and that's what David was speaking about. So again, it's not necessarily that we're here to complain, like he said. We're just telling you the challenges that we're faced on trying to attract and train people to this community. So it's very competitive. I can tell you, we interview a physician, and most of the times they'll say to me, I have 6 or 8 other interviews I'm doing across the nation. And so you're having to find a way to attract them on to choose this community. So it's a side that, we look for partners. We're looking for our community to support these physicians as they relocate here and get adjusted to the community. The more likely they get adjusted well, the more likely they are to stay. And so that's an important thing that we really do try to do. So by, where we're at 2020, if you can look on the next slide, sorry about that, where we are with the number of staffed beds, The highest one, sorry, I keep pointing over there. The top one is the licensed beds. So we're licensed. What we staff for may not be what we're licensed for, but you can see the deficits consistently from September 23 to August of 2025 of where we're at on getting those qualified workforce into our area. You want to go to One Big Beautiful Bill?
Yeah, the One Big Beautiful Bill. We heard that mentioned several times, I think, in the session this morning. And, you know, the thing about it is, yes, we're concerned about the One Big Beautiful Bill. And, you know, it is going to take, you see the CBO score, the 10-year CBO score on a number of things that are contained in the One Big Beautiful Bill. And it's going to take a lot of money out of healthcare. And the thing I will say is hospitals are resilient. This is not the first time that we've been faced with these challenges. When I got into healthcare in 1988, the thing called prospective payment system, DRGs, had just hit in 1985. People that had been in healthcare and were used to a cost-based reimbursement model, they thought the world was coming to an end, right? And you know, there's no way we're going to survive this. And guess what? You do. You innovate, you change your organization, you do. We are resilient, we are adaptable, and we end up surviving that. And I saw a slide not long ago at a presentation that kind of looked at a timeline over, you know, the last 40 years or so of all the different things that we have been through, the Affordable Care Act, you know, the prospective payment system, various things that have, you know, big pieces of legislation that have come along. And we do have to think differently about how we're going to operate. We have to think differently how can we innovate? How can we take cost out of the operation? How can we deliver care in a different way? But if the Big Beautiful Bill survives in its current form, there is a lot of money that is going to come out of healthcare. And the next slide kind of looks at how that kind of cascades over the next several years. You know, starting with the passage in 2025 and then in 2026, you know, 80-hour work requirements, loan limits for graduate and professional students. So really nothing that was going to affect significantly our hospitals. In 2027, eligibility requirements, you know, for Medicaid recipients, that's going to change. So some of the people are going to come off of the Medicare rolls and not have coverage anymore. Guess what? Those people are still going to show up in our hospitals. They're still going to need care. They're just not going to have coverage. And I think one of the things as we looked, you know, we've talked about payer mix. One of the things that we have seen in West Virginia that's been a positive after Medicaid expansion is our self-pay. People that were actually responsible for paying for their care out of pocket really came down significantly. Well, in 2027, if people are not continued eligibility for Medicaid, they're going to go back into that bucket. They're still going to need care. There's just not going to be a payment methodology for them. So, you know, we are talking about, you know, how we can retool our organizations, how we can become more efficient, how we need to change our structures in some way to adapt to that. But I think the thing is that, you know, we've been through this before. This is not the first time that we've been through major changes in our healthcare system. And, you know, in Raleigh General's case, we've weathered that storm for 104 years. RH has done that for many, many years as well. So I'm sure we'll continue to do that. One of the big things, and the next slide is, well, no, that's it. That's the right one. Yeah, is the Medicaid directed payment program. And, you know, this is something that, you know, has really helped our hospitals. And this is what I was referring to with the provider tax, where, you know, hospitals and physicians are taxed based on our net revenues, and then we pay that money to, you know, the government. Money goes to DC, gets matched, and comes back, and it's a bigger pool of dollars to fund our Medicaid program. With the Big Beautiful Bill, there are going to be some changes to that. Again, if things survive in their current form, we're looking at a potential annual loss of funding for hospitals in West Virginia of over $1 billion. So every hospital in the state is going to be impacted by that. So, you know, we are advocating for changes and trying to make sure that everybody, that are in positions, to make laws and policy that they know what's coming. Because again, hospitals are such a big part of the economy, not only here in Raleigh County, but in just about every community across the state. I saw a map not long ago where the county, the outline of the county was actually replaced by the logo of the largest employer in the county. And in most of the state, that logo in each county was some healthcare organization. So, it's something that we need to keep our eyes on and be aware. The legislative priorities and, these are things that we're advocating. We want to ensure access to care and maintain hospital financial viability. That's what we've been talking about. We want to streamline regulatory, administrative, and operational processes. Those are the things we've been talking about. Strengthen community care. Todd shared some good examples of what his hospital, our hospital, is doing some similar things to, provide services in our community to address some of the insecurities in the area, whether that be food insecurities, housing insecurities, those type things, either through us or in partnership with others. And then to support and protect the healthcare workforce. These are the things that are keeping us up at night. These are the things that are our priorities when we're talking with our legislators.
Can I just pipe in one thing too? One of the things too, and David's referenced this, but is we've had to change. We've had to change things in healthcare, and we're continuing to have to change. So innovation is a big part of what we're trying to do. For our organization, and I'm sure that we aren't alone in this, but we have over 25 applications that we currently use for AI to help us innovate the care that we provide for our patients. So we have things, if I have a scheduled service and a patient doesn't show up, I have labor, I have expense sitting there and no revenue to offset that. So we've used a platform now to help us predict what patients won't show up based on their past behavior that helps us to make sure that we're being more efficient at what we're trying to do. So again, we're trying to innovate and do things differently so that we can, again, make our patients safer, have the experience better for our patients, but also reduce costs. So, I have, like when I talk to leaders in our organization, sometimes they go, well, Todd, you want me to focus on quality and you want me to focus on this, but I can't do both. And I said, the problem is you don't have a choice anymore. We have to do everything. We have to have great employees, great patient experience, great finance, and great clinical care. So you don't really get a choice anymore. We have to do everything. The challenge is out there, so we're having to innovate to get that way.
Yeah, absolutely. The other thing that we like to do is, periodically remind the community of what our organizations mean to the local economy. And, we produce at Raleigh General every year a community benefit report that kind of summarizes that. Raleigh General last year, about 980 employees, a direct payroll of over $91 million that's coming into the local economy. So I don't know, what metric you apply to that as far as an economic multiplier, but it's a big number. And so we're one of those industries that we employ people based on our volumes. So we want to have quality hospitals here that encourage people to use our services. If a surgery goes to Charleston or if a surgery goes to Morgantown, not only does it take that family out of the community, it also takes those dollars out of the community, and it takes a part of a job out of the community. So I think what Todd and I both want is to operate hospitals here that have the scope of services that provide most of what our patients need here, to do it in a very quality way so people can seek care in Raleigh County, that they don't see a need to go to another community for that care. Another way, and this is a way that Raleigh General is a little bit different from some other hospitals in the state. Raleigh General is actually investor owned. I mentioned earlier that we're a part of LifePoint Health. So LifePoint operates about 130 hospitals across the nation, combination of acute care, behavioral health, and inpatient rehab facilities, but in over 30 states. And we are a tax-paying organization. A lot of hospitals are not-for-profit and are exempt from some of those taxes, but we pay direct taxes of about $21 million. Ryan will have to keep me honest here, but I have heard that we are the #1 contributor to the city of Beckley's B&O tax. Is that correct? Maybe?
You're up there.
Yeah, we're up near the top. So I've never verified that number, but you know, it's a big number. And then again, we take care of everybody regardless of ability to pay, and that amounts to a lot of charity care. So about $25 million a year in charity care. So it's a big contributor to the local economy. I know we're happy to do it. We're proud to have been part of this community for well over 100 years and hope to be here for at least 100 more. So.
All right. Well, let me talk a little bit about our community benefit. Again, like I said, David and I work together again on things that are important for the community at large. Again, we are required, one of the things that's a little different for the not-for-profits is we're required to do a community health needs assessment. So we complete one every 3 years. We just completed one in 2025. I ask if we do this in the future that you please give us information on that. We just completed it. What do you think the #1 health concern is in our area based on our feedback? What was that? So the #1 thing is obesity and healthy lifestyles. So that's again what people say is affecting what we're doing in this community. So after that assessment, we worked with community members, we developed a plan which covers 4 areas. One is education on healthy lifestyles and unhealthy behaviors. Again, the speaker at 3 today is from our lifestyle medicine division to talk about healthy lifestyles. Again, it'll surprise you. We see this all the time, and I'm sure David sees this too, about the patients that think that if I feel okay, I don't have to take my medication, no matter what it is. So it's an important thing for people to understand that what they eat affects how they're healthy they are. So we are again doing education on healthy lifestyle and unhealthy behaviors. Again, substance use. It's very familiar in the area as far as substance use disorders, alcohol, tobacco, and vaping. We do a lot of education. We hand out Narcan to people. Those are all things that we're trying to do to help tackle substance use in our area. Housing and homelessness is one of the things, and you heard that a little bit this morning referenced with the candidates. Again, we find people that, especially our adolescent psych patients, that we have to ship to Arizona, that we have to ship to South Carolina because we can't find a place for them. So it's a big issue in our area. And just basic needs. We have people that we will discharge from the hospital, they don't even have food when they go home. And so it's important for us to find ways how we can make sure they don't come back to the hospital. We love to have them there, but we don't really want them back. We want them to be able to live successfully in the community. So additional ways that we serve our community is free healthcare screenings. We do this periodically, like for Heart Month, we were checking people's level of blood pressure, running blood fats and other things like that we were doing. We have a mobile health unit, which I showed in a picture earlier. We do community education. We have somebody that full-time works for us, does community education on prevention, lifestyle, nutrition. Student education, we have, I don't know, probably any time about 25 medical students that we're training in our hospital, nurses, allied health professionals, et cetera. And the ARH Foundation also supports our community partners like Salvation Army, United Way, Away, and others, because we don't do everything in healthcare and we don't claim to do everything in healthcare. We have to partner with others to help take care of our community. And so that's some of the ways that we demonstrate that through our community benefit.
On a little broader level, just looking statewide, you know, again, West Virginia hospitals are a big part of the economy, a big part of each individual community. 2024, the community benefit to West Virginia communities about $1.12 billion, $655 million of that. Medicare and Medicaid shortfalls, about $186 million in provider taxes, $182 million in uncompensated care, and $92 million in community programs and education. So we appreciate, everyone's being behind our local hospitals and our hospitals across the state. Again, I think if our state's going to be successful with economic development, we need a very strong healthcare system to support that and be able to bring folks into the area to work. Just finally, we're going to take a couple of questions, but again, knowing that workforce is a big part of what we talked about, we just appreciate the sponsors of our session today, WVU Tech, New River Community and Technical College. Without these educational institutions, neither of our hospitals would be in business. We really depend on a strong education community to support us and produce the workforce that we need to continue delivering our mission. So I want to thank you guys for sponsoring the session today. And we'll take a couple of questions, and if anybody has anything that's on their mind. I think we bored them to death. I think.
Oh.
Never give two hospital CEOs a microphone, okay? It's not a good thing to do.
Well, I do think it's refreshing to see both of you up there working together on this and knowing that you're both working together for our community, so thank you for that. And my question is, with the AI development, what is your biggest challenge as hospitals with the advancement of AI?
I would say, we just rolled out a new product, probably 3 weeks ago, virtual sitters that we're doing. One of the things that we have is staff that you have a highly trained nurse, they don't want to sit and watch somebody that could potentially fall. And sometimes we've had to do one-on-one, I'm sure David has to do this too, one-on-one sitters to prevent people from falling. But when we were rolling that project out, I could tell you is people are afraid because they're afraid of losing their job. So what we've had to communicate a lot to our employees as we've rolled out some of our technologies is that we're not trying to supplement you. We're not trying to take away your job. We're trying to augment the work you're doing so that you can be functioning at your highest level. So we don't really want a registered nurse to be sitting and watching a patient for 12 hours to see if they'll get out of bed. So we've invested in that as something to help our workforce make sure that we don't wear them out. It's very stressful in healthcare. We deal with the lives and deaths of people, and that has a huge impact and a huge emotional toll on a lot of employees. And so we have to find ways to relieve that. But one of the things, like I said, recently I've seen more, as we've rolled out AI, is it going to take my job away? And that's a valid thing to be concerned about. So we have, tried to reassure people this is augmentation. This is not replacement. So.
Yeah, and I think the thing that we're looking at is there is so much out there. Everybody seems to have an AI solution, right? And the concern for just making sure that we've got proven technology, and we've got a lot of AI that's being embedded in different pieces of equipment. EKG machines, for example, do a preliminary read, but it's not always right, so you still have to have someone that's over-reading that. A lot of that technology is true, in some of our advanced imaging equipment that has AI embedded. You also, our electronic health record, a lot of things like in ambient listening, complaints that we get about when someone has an encounter with their physician is the physician never looked at me, right? Or the provider never looked at me. They were too busy putting things into the computer. And so there are, technologies out there that are kind of listening to what's going on in the room and is putting those notes together so that the physician or provider is not so focused on typing everything in. But again, I don't know that all of those technologies are proven yet, and I know our company is kind of proceeding cautiously in adopting technology and making sure that it's ready for prime time.